Hey guys, welcome back to the Foam Frat podcast. We got an exciting episode. I have Dr. Banerjee back on, still talking pediatrics, but this time not cardiac arrest. We're looking at traumatic brain injuries and a new pre-hospital protocol that they started to implement. So Sam, you listened to the episode. Kind of cool seeing 3% in Keppra now in the pre-hospital side of it. I know as far as like flight services go, you know, that's been pretty common for the last few years, or to see them kind of going in that direction. But to see this on like fire departments and EMS departments, I think that's really cool to see that.
Yeah. Pediatric TBI is interesting because in my brain, as I was listening to this, it's like overlapping with a couple other time-sensitive, neuro-involved pediatric things. The two things that came to mind were like water intoxication with pediatrics, where, and you guys are talking about serum osmolality and stuff too, so that especially like came up in my brain. Like you have water intoxication where the sodium goes too low and they can get comatose and have seizures and altered mental status and stuff, and you have to recognize that really quickly. And then you also have pediatric DKA patients where the typical standard of care is that because they can have those signs of increased ICP when you're lowering their glucose, that you have like a dextrose line hooked right up to whatever line is running, just in case you see signs and symptoms of the increased ICP. The common thread between all of those was like kids can get increased ICP really easily, and it can happen pretty quickly. They're so different than an elderly patient who has an old atrophied brain and they can get this subdural and then nobody notices it for like quite a while, but they have this like growing, developing brain, and there's not a lot of extra room under the hood, which is why I think it's such an interesting thing to move some of these treatments for increased ICP into the pre-hospital realm. I think that makes a lot of sense, especially when it comes to pediatrics.
Yeah, we don't have a lot of good pre-hospital data that actually in-hospital data, that prophylactic Keppra is helpful. And so this may be, you know, albeit it's kids, this could be the study that shows that in patients with suspected TBI, you don't really have to wait for them to seize to give them something that'll stop them from seizing. And so starting off with some of those medications that you would give further down the line in someone who's actively seizing to prevent it in the first place, because we know that that can be like super detrimental in a TBI when a patient starts to seize from it. So yeah, hopefully you guys will enjoy the discussion. He put together some cool slides and stuff, and he kind of does like a little presentation. I was expecting a podcast, and he came on and had all his slides laid out and everything, but it was really cool to see. So yeah, let's roll it.
I know this paper isn't exactly out yet, but this is what you guys are currently doing, correct?
Correct. It's a pediatric TBI protocol that's pretty much unique for the country. No one else is doing this. And we were kind of approached by a pediatric trauma surgeon, said, we do this when we come to the ER. Can you do it in the field? So after a lot of, political arm wrestling, kind of got this to work and had really good outcomes.
Awesome, man. Well, yeah, let's get into it. So what does this protocol look like?
Well, you look at pediatric TBI and basically traumatic brain injury in general. It's a acquired neurodegenerative brain injury that comes from a blow or a penetrating injury to the head or body that disrupts normal brain function. So basically, it's a hard hit to the head, and that can cause a lot of damage. 61% of moderate to severe TBIs have some form of disability, and 56% of patients will die within a year if the initial presentation of GCS was less than 4. So that's pretty alarming right there. That's severe TBI patients. And some people with TBI could take 6 months to recover to basically becoming a normal state. So a lot of issues going on with TBI. Amazingly, too, is that your life expectancy is about 9 years shorter even after surviving a moderate or severe TBI and receiving inpatient rehab services and doing everything right. And even the people who do recover from this, 10% will have developed chronic seizures, and 57% will have some form of disability, i.e. modified Rankin score of greater than 2. And for people who don't know what Rankin score is a sign of disability. Normally, we're walking around with a 0. A Rankin score of greater than 2 means you have some form of disability that you need a little bit of help with, and that's Rankin score of 3. 4 and 5 are basically moderately to severely disabled. So that's quite alarming that many people would be requiring some form of help or therapy after the TBI. So what we're going to do is focus on TBI and pediatric TBI specifically, and there's some things we're doing that are kind of unique and have shown some really good promise. So with pediatric TBI, there's about 475,000 cases a year between the ages of 0 to 14 in the state of Florida. Pediatrics is basically 16 and basically under 16, so 15 or under. 37,000 were hospitalized, and about 2,600 people died because of their injuries. And those numbers are pretty alarming to begin with, but realize that this doesn't take into account people who kind of shrug it off and walk it off and don't come in and something bad happens. So those numbers are actually lower than they actually should be. So when you look at peds, the different age groups cause different injuries, right? So the young infants, usually child abuse is the reason for their TBI, shaken baby syndrome. Toddlers, school-age children basically have child safety issues, pedestrian injuries. And on an interesting note, too, we did a deep dive on our trauma alerts for pediatric patients. And when the child protective seats are facing forward towards the window, there's significantly higher traumatic injuries than if they're actually facing the rear. And I know a lot of parents like to say, hey, I want to make sure I can see my child. But the problem is, if you are in an accident, you have significantly increased your risk of having a severe TBI and mortality for your patient. So although it's kind of uncomfortable, it's always better to put the child safety seat towards facing the rear window. With adolescents, obviously bicycle, motorcycle, sports-related head injuries occur. So those are the basic 3 breakdowns of age and types of injury. So in general, there's 3 forms of TBI that occur or basically cause TBI. So you get your direct impact that causes a TBI. You have basically a shearing injury that causes that as well. And also you have a shaking syndrome. So basically you fall and you have basically moving your brain in your head from a fall, or kind of whiplash injury that you get with your brain. So those are 3 main types of TBI that you can have in general. So it's kind of unique to Polk County because we're a very large county. We're 2,010 square miles. Our population is about 850,000. We run about 125,000 calls a year and about 102,000 EMS transports, and about 900 pre-hospital providers. So we're a large county, but we have no pediatric trauma centers in our county. So how did this whole process of protocol occur? So we were basically approached by Arnold Palmer Hospital, and Dr. Plumley, who's the head of trauma surgery there, said, would you be interested in doing a severe pediatric TBI study? We would cover all the costs for this. We will train, supply you with all the medications, and it's for free. So, get your ears picked up and said, hey, anything for free? Sure.
Yeah.
So said, look, let's get some parameters, what we're trying to measure, right? So we're looking at, we want to lower the intracranial pressure for severe pediatric TBI cases. And we want to administer 2 neuroprotective agents that we kind of normally do in the ER, but we want to see if you giving it in the field makes a difference. So the 2 medications were Keppra and 3% saline. Arnold Palmer Hospital covered all the costs. And the interesting thing is, do you know how expensive this was for both medications?
Oh, man, I couldn't even guess. So you're saying how much do those cost a piece?
Together.
Oh, together? I can't think it would be that much, but I don't know how much Keppra is.
So it was $20.
Okay.
So they would all come in little packages with 3% saline and Keppra in a little package for, it basically says pediatric TBI. The whole thing costs $20, and it's probably the best $20 that they've ever spent, and we're going to continue this.
So my Keppra that we carry on the helicopter, it comes in like these 500 milligram vials, and there's, we have 6 of them for a total of 3 grams. So we have to manually pull up all of those and mix it. You're saying that Keppra is already mixed in its own bag?
We have to draw it up and mix it, but it's the vial and the medications are there. for the crews to administer.
Gotcha. Okay, so you're still pulling it out of a vial and putting it into a bag.
Correct.
Gotcha.
So we were looking at things that mortality do people survive more if we try this? Morbidity, what's their life function, quality of life afterwards? How long are they in the hospital versus what they were in the hospital prior to this? And we were looking at CPC scores or Rankin scores on discharge. And we'll cover that a little bit later, but that's basically looking at the level of disability that the patient has after the TBI on discharge. And basically wanted to compare all our times before we started this in October 2023 and basically 2023 moving forward. So Arnold Palmer, a great hospital, but remember I said we're 2,010 square miles. We're larger than 2 states, Rhode Island and Delaware. So we know Arnold Palmer covered the east side of our county, but we kind of need a pediatric trauma center on the west side of our county. So I talked to Tampa General, which is the other major pediatric hospital on the west side of the county, and Dr. Thatch was the head of trauma there and kind of obliged. And so this is how it kind of worked out. So that's our county, 2,010 square miles. Arnold Palmer is up here towards Orlando, and then Tampa General is out west. So that basically, we split the county down in half. And if you're basically on the east side of the county, and that's usually 27 or 33, anything east of that would go to Arnold Palmer. Anything west of that went to Tampa General. And that was kind of an arbitrary line we did. It kind of split the hospitals in two and basically divided and conquered the county as best we could. So here's our protocol. It was kind of exciting. We kind of like brainstormed with Tampa General, brainstormed with Arnold Palmer. We added our own 2 cents and found a way to kind of make it work. And this is what it is. Pediatric trauma alerts are at basically 15 and younger. So if we have a patient that comes in and we present on scene and they're looking at the patient and they says, well, looks like they have a significantly elevated intracranial pressure, possible impending cerebral herniation, and they're unresponsive, this is something we're going to be initiating this pediatric TBI protocol for. So any patient with a GCS of less than 8, and they would be intubated or have a supraglottic airway, plus if they find any other signs of the following: unilateral or fixed or dilated pupil, unilateral paralysis, they're decerebrate or decorticate, or they're having seizures after the initial injury. So any one of those signs plus being unresponsive would be someone we would include in the study. And again, this is basically for severe TBI patients.
One question too I had on this one. So do you guys, because you guys have full RSI protocol, right? You can use paralytics as well as your sedatives. Do you give any insight as to, hey, in this population, use succinylcholine so that way we can see what's going on and they're not staying paralyzed? Or is it fine to use rock? It doesn't really matter. And you're assessing what they were doing before you intubated them.
Well, wait, I will have that covered shortly.
Oh, okay.
Wait, there's more. So you have basically your 3 categories of severe TBI. You get severe, basically GCS 3 to 8, moderate is 9 to 12, and mild is 13 to 15. So we're really going to focus on the severe TBI patients, and we're obviously going to expand this as we go on. So basically, when we approach an airway, initially do the bag valve mask, jaw thrust with C-spine precautions. We have a DEI protocol, but we're really focusing on induction and sedation only. They want us to avoid paralytics if possible, because it does limit the neuro exam once it gets to the hospital. So after talking to Arnold Palmer, this is basically one way we kind of agreed on doing this specifically for our patients. So they would get lidocaine 1 milligram per kilogram prior to endotracheal intubation. And this is basically done to minimize the intracranial pressure spike. We use Versed per the Hantevi, which was 0.05 milligrams per kilogram. Again, this was both IV or IO. Ketamine was 2 milligrams per kilogram, same IV IO. And we would avoid etomidate if possible. Of course, with drug supplies the way they are, we sometimes have to weary over to etomidate. But I think we've been able to be lucky enough to only use ketamine for our induction agent only, and that seemed to have worked on these people specifically because they are unresponsive and they're not someone who's fighting the tube. They're really so injured that they don't really fight anything we have, and everything has kind of worked out that we've not had to add paralytics. But the big key is the etomidate is not what we're using at all. So the reason is very simple. Is ketamine is also used for status epilepticus. It has minimal effects on intracranial pressure. It does provide analgesics for the patients because even though they're unresponsive, they still can maybe experience pain. And it also works by catecholamine responses, so it doesn't affect blood pressure. So that works out well for these patients. And if you look at status epilepticus, which is potentially a side effect of a TBI, and it affects about 180,000 people a year, and this is basically originated from two receptors. You have the GABA, which is an inhibitory receptor, which is all the medications we normally use, like Versed, phenobarbital, and basically that's an inhibitory method. And then you have NMDA, which is excitatory method, which occurs through glutamate. And so the problem is during prolonged seizures, GABA receptors drop. And because of this, the binding of the benzodiazepines and phenobarbitals don't really work. And that's why these anti-epileptics fail. So what ketamine does, it works in a different way in that we know that GABA receptors are down, but the NMDA receptors are antagonized by ketamine. So the problem with the NMDA receptors is they bind excitatory neuroreceptors like glutamate through the use of calcium. And what ketamine does is block that. And by blocking that, you inhibit the amount of seizures that occur. So that's how ketamine, so that's why we've really focused on ketamine as a preventative for seizures, also as a better induction agent. And this is kind of the cartoon of how that happens. And basically by blocking glutamate and blocking the NMDA, we get much better control of seizure patients post TBI.
And I've seen that as well. We've had patients, like adult patients, who are in status and they're on their, 12th, 15th milligram of midazolam, and those GABA receptors have downregulated. And like you said, the NMDA upregulate, and the ketamine terminates that. Typically, and I was just going to ask your opinion on this, in the ED, if somebody were to come in, like a kid with a TBI, is ketamine your first line, the thing you're going to first? Or would you use something like etomidate and propofol? Because propofol still got the anti-seizure properties.
It does. I would probably use ketamine and propofol. Ultimately, the brain is very irritated. And the difference between etomidate and ketamine for induction agents are not significantly different. And with trauma specifically, etomidate can lower blood pressure, especially if there's kind of renal injury that, these are mass trauma patients, so we don't know what could be the cause. And because of that, I kind of steer away from etomidate.
And people may listen to this and still be in the, oh no, you can't give ketamine because it increases ICP. And, obviously that's been debunked, and the thing is I do sometimes stay away from ketamine if their blood pressure, because typically you're going to see these elevated blood pressures. This is what I've seen in TBIs, like their blood pressure is 180 over 130, 200 over something. And so for that reason, not because I think that ketamine is going to increase their ICP, but I know ketamine does increase the sympathetic tone a little bit. So if I am doing something like ketamine, I'll also do something like some fentanyl to try to blunt some of that sympathetic tone. Are you guys working fentanyl in here at all? I saw the lidocaine that you're giving. Is there anything else for blunting that sympathetic tone? Or are you saying the ketamine will cover analgesia and sedation, so we're just doing that?
So interestingly, we are actually working on these TBI patients like they were stroke patients.
Oh, okay.
And I'll cover that in a little bit, and I'll show you what we're doing for the transport of these patients.
Oh, interesting.
So obviously, if we have an IV or IO, we're going to do 1 milligram per kilogram IV. or IO. And if we can't get an IV or IO, get a 3 milligrams per kilogram IM if they're in status epilepticus for pediatric patients. And that's probably the standard dose for everybody. But for our TBI specifically, and that was kind of a background of why we're using these medications, 3% saline would be given at 5 milliliters per kilogram with a max of 250 mLs, either IV or IO. And with, at the same time, given Keppra, 20 milligrams per kilogram with a max dose of 1 gram IV or IO for these patients based on their age and weight. And a lot of times the 10-year-olds are weighing more than adults, but we still only max out at 1 gram.
And are you running this in over gravity, the 3%?
Correct. So once we've infused both of these medications, the theory behind this is every time you go to the ER, anytime someone has a head injury, everybody gets prophylactic Keppra. Keppra is an anticonvulsant. It's safe, especially in pediatric patients. It manages potentially post-traumatic seizures and has very low toxicity, unlike Dilantin, which was used before. And basically, it's empirically used in hospitals, so it's a very easy medication to use. The interesting thing with Keppra was, though, based on the weight, we had to adjust the dosing concentration or quantity. And, you know, when you're in these kind of situations, it's really hard to do easy math. So one of our training officers created a chart. So basically you could scroll over based on their age, their weight, and what dose of Keppra they would have. So this made life a lot easier for our crews as well. 3% saline, the theory behind this is basically it extracts fluid from the cerebral tissue via osmosis, diminishes the effect of secondary brain injury. Isotonic saline, basically there's equal flow of fluids. Hypotonic basically causes the fluids to increase in the cell and it swells up, kind of like apoptosis and ruptures. And hypertonic saline basically extracts fluid from the cell and makes it shrink. So everything's based on osmolality. And this equation here, if you add 3 times the salt sodium, which is 500 plus, it makes the osmolality number significantly higher. And as you know, when the osmolality is higher, you cause a movement of fluids from high concentration to low concentration. And as a result, what that does, it causes the cerebral edema that can occur after a severe TBI to diminish. And it kind of works like mannitol, and I don't know if you have that in the helicopters, but 3% saline is actually very inexpensive. And as a result, it'll help decrease the swelling of the brain.
And it's not as sticky as mannitol. No, we don't carry mannitol on the helicopter, okay. But I've carried it, or I've transported patients on it, and a little bit gets on the ground, and it also has an effect where you see the patient start massively diuresing and peeing and drop their blood pressure. So I think 3%, I tend to like that more than mannitol as far as hypertonic solution.
I think it's more titratable too. I think that's why it works so well. So the big things when we transport these patients is that you want to avoid hypoxia, want to keep oxygen saturation about 95%. Our end tidal CO2 goal is between 30 and 35 millimeters. The other things are make sure that you have an appropriately sized collar, that their head's not flexing or extending their neck. You want to put the head in midline for cerebral venous drainage. And you want to elevate the head about 30 degrees in a reverse Trendelenburg position. So it allows the head to allow the blood to drain away from the head. Again, decrease swelling, decreasing intracranial pressure. Now, this is what we talked about earlier that you had mentioned about what do we want to do for blood pressure parameters and how we want to be controlling them. Based on age, we want to keep the MAP above 60 if they're 0 to 5. If they're 6 to 12, we want to have the MAP above 70. And if they're greater than 12, we want to have the MAP above 75. Now, they are lucky that the TBI patients don't become hypotensive despite being intubated. And the 3% saline kind of help maintain this along with the ketamine. But they definitely want us to make sure the pressure is above 60. And we would do what we would normally do in our protocols for the shock patient to get the MAP to be above the numbers that was required. and that involves either a fluid bolus or if they have to give Levofed, however we have to do to maintain that map. Thankfully, we've not had to do any additional pressors to make that happen. So what we did was, well, let's look at the outcomes. Are we doing well? Is this kind of working or not working? So we talked about CPC scores before, and that was basically a cerebral performance category scale. And it's kind of like the Rankin score. Instead of 6, it's 5. And what we're looking for is good outcomes. So CPC score of 1 means full recovery or mild disability. CPC 2 is moderate disability, but independent activities of daily living. So these are kind of like Rankin scores of 0, 1, and 2. Negative outcomes are CPC 3, 4, and 5. Obviously, 5 is really bad because you're dead. 3 and 4, you're kind of in a vegetative state and really dependent on others for function. And we talked about how the grim numbers were before for people who have severe TBI. Now, as of 10/1/23, where we started this, we've had 4 total TBI patients that have met criteria for this protocol. 3 of them had a CPC score of 1, which is great. Those went to Tampa General. We've had 1 CPC score of 2 in 1 patient. And that was a 13-year-old kid that was basically blasted by a car in our county, and they were flown to Arnold Palmer Hospital. They did an amazing job, and the fact he has a CPC score of 2 is pretty amazing. So the numbers have been pretty good, and so we're going to continue as we were. And that's basically a summary of what we did. And Dr. Plumley is the guy who's the head of trauma surgery at Arnold Palmer, who helped initiate this whole thing. So a lot of credit goes to him.
Man, that's fantastic. When can we expect to see this paper come out?
We're going to wait about a year. Pediatric trauma isn't very prevalent, even though we have a pretty traumatic and busy county that we live in. So if we get 5, 6, 7, we're going to do a white paper. Initially, we've submitted it, the initial abstract to ASAP for the one in Las Vegas in the end of September, which has been accepted for presentation. So that will be an abstract that will be presented as an oral presentation at ASAP. After that, we'll probably write an article after that, but that will be something at least to start off with. The numbers are small, and we may have to do an annual reevaluation of these patients. But if 100% of the people we've had with TBI with this protocol have gone home neurologically intact, I think that's a great start to pediatric trauma care.
Oh, no, absolutely. How was the buy-in from the crews? I mean, obviously you're their medical director and you said, hey, this is what you're going to do. But as far as like the training goes and them adapting this, what was that experience like?
It actually was really good because I think you get great professionals at Arnold Palmer who came in and said, look, we're here to help you. You look at these kids where we couldn't do anything before, and we'll train you, we'll show you, make it as easy as possible. If you have someone with these criteria, they're unresponsive, you've done your airway, let's do it this way. Because with normal adults, we'll use etomidate or Versed based on whatever's available, but we really wanted to go down this pathway for pediatric TBIs, and the crew's buy-in was great, and I think the results are great, and a lot of that is because the crews really bought into what we did.
Man, that's fantastic. Well, Dr. Banerjee, thanks so much for coming on and showing us this. I can't wait to see the paper. Maybe when that comes out, we can do an update and follow up on it because, like you said, it's not super prevalent. You said you had, 3 patients or 4 patients? Four patients since in over the past year, right?
Almost a year, yeah.
Yeah, almost a
10
year.
months.
So
Yeah.
Is there a target you're looking for?
I would love to get to 25.
Yeah.
Not in a bad way. Obviously, I don't want these kids to get hurt. But, if we kind of did it and they got well, and that may be 2-3 years down the road. I don't know. But already Tampa General has modified what they're doing. And I think this is kind of going to be a game changer for the rest of the country because it's cheap and it works. So let's continue and hope this works and stay the course.
Awesome. Thanks so much, man.
You're welcome.